It's 2 o'clock, and it's my pleasure to welcome you all to this week's NORA Friday afternoon webinar. I am so happy to see so many attendees here today. More than 130 people have registered. I'm sure this is due to the highly relevant topic, the Norwegian model of COVID-19, and our distinguished speaker, Professor Arnoldo Frigessi. I can see that many of the attendees are regulars, but today we also have quite a few new participants. So therefore, before I introduce Arnoldo, I can inform you all that also today the presentation will last for about 30 minutes. Then we will open up for questions. For questions, please use the Q&A button at the bottom of the screen. You can write them up during the talk or afterwards, and I will read them up one by one for Arnoldo.
And I will try to understand them.
Yeah, I would also like to say that if you don't know NORA, the Norwegian Artificial Intelligence Research Consortium, please visit our website nora.ai and sign up for our newsletter and next week's webinar. My name is Claes Pettersen. I'm the CEO of NORA, and it is my pleasure to introduce today's speaker, Professor Arnoldo Frigessi. Arnoldo is a professor of statistics at the University of Oslo. He is the leader of the Oslo Center for Biostatistics and Epidemiology and is director of BigInsight. BigInsight is a center of excellence for research-based innovation, a consortium of industry, business, public actors, and academia, developing model-based machine learning methodologies for big data. Arnoldo is also group leader in the Center for Digital Life Norway. Originally from Italy, where he had positions in Rome and Venice, he moved to Norway in 1997 as a researcher at the Norwegian Computing Center, before he became a professor at the University of Oslo. His talk today is highly relevant. The title is The Norwegian Model of COVID-19, a spatial modeling of the early phase epidemics. But one thing, Arnoldo, before we start, we had a meeting at your lab about 1 year ago. And in my meeting notes with big letters, I can find a note to myself. It says, meetings at Arnoldo's lab should preferably be organized Friday afternoon, as they often have cake at that time. So, Arnoldo, did you eat cake today?
No cake today. No cake today. But as you see, I'm in the office, and this has happened this week. But there is no cake. And we were maybe 10% or 15% of the usual number here, and it was no cake. And then, of course, there's also the discussion of what cake, because not all the cakes are good cakes.
Yeah, I remember the tiramisu cake. It was very good.
Tiramisu, that was good. But yeah, there are many colleagues and students that are wonderful in preparing cakes. So it's really delicious. But today I'm in fact quite hungry because everything is closed here, and I'll try to give a talk with some hunger inside.
I look forward to it, Arnoldo. Please, the screen is yours.
Thank you very much. And thank you very much, Claes, for introducing me with all these nice words. In fact, it's a nice fresh up to remember who I am in case I forgot, which is a good feeling. So now we share the screen here. And I think, is it fine? It's fine. Good. Then I can do this here. And I hope you can also hear me well. So I'll try to tell you a little bit today about the modeling that I've been doing together with a wonderful team at Folkehelseinstituttet. Aha, and this doesn't work. So we will go back here a second and try again. This one here, and then this one here. And maybe this will work now. Yes. So here this is the wonderful team of people who have been working very hard from the beginning of February, day and night, I would like to say, trying to produce relevant information and predictions for Helsedirektoratet, the government, and the ones who had to take the decisions. And it's my pleasure to acknowledge Brigitte, Gunnar, Alfonso, Anja, Francesco from the Department of Methods Development and Analytics at Folkehelseinstituttet, Suva Engebretsen at Norsk Regnsentral, and Kent Engomonsen from Telenor Research. This here is the prediction of yesterday, a couple of days ago. So here you see red dots. The red dots is real data. Every dot corresponds to a day from the middle of February until a couple of days ago. It's the number of new COVID patients that are admitted to all the hospitals in Norway. And as you see, it went up just between the end of March and April, and then it has been decaying systematically. The very, very, very few cases now, currently, new patients that are admitted. Now, the blue shaded area that you see here is our model output. It is until where you see the data, it's just to show you how our model, which estimates lots of parameters, and I'll tell you more about it in a minute, fits to these data that are really used to estimate the parameters. So it's not a surprise that the fit is decent, but as you see, it's not perfect. And there is a lot of variation and variability in the data that not necessarily is captured perfectly by our model. And then you see the most important part is the prediction that comes here at the end. This is what we expect to happen in the next 3 weeks. The number of new COVID patients will remain very low, might even disappear completely to go down to 0. And you see uncertainty bands. This is something that you can't currently measure today. So it's a full estimate from the beginning of the epidemics until the next three weeks. It's the prevalence, it's the number of active, infected individuals that are walking around in the streets every day. And you see there has been a peak again in the middle of March, somehow here, a bit before the hospitalization, because that's when they get infected, about 9,000, 10,000 people, and then it's going down here until where we are now today, with very, very few, some hundred people that are infected. And if I look to a geographical distribution, I see a map that now is almost yellow everywhere, which means that we do not expect to have any infectious individuals in most of the municipalities, in most of the community in Norway. But you see some light blue, this is Oslo, you see some light blue here, where there are still some cases, maybe between 1 and 10, maybe up to 50 or something like that. This information can also be quantified. We can say that the number of people that have been infected so far in total is between 30 and 40,000 in total. This is not a big number for a population that has 5.5 million people. How many of these had symptoms? We estimate that 22% roughly have symptoms, while the number of individuals who have been confirmed positive so far is about 8,500. So roughly 23% of the infected people are really detected and found by the current system of testing, which is actively trying to find infected individuals. You all have heard about reproduction numbers. Reproduction numbers are important, are 0. It's a parameter that we estimate. In fact, in our models, we have a reproduction number that is acting until the 15th of March, one that is acting from the 16th to the 16th of March to the 19th of April, and then one thereafter. And here you see our current estimates. So the first R0 is between 2.5 and 3.6. The second one here in the middle, after the intervention of the 12th of March, after the schools were closed and so on, is between 0.46 and 0.62. 95% credibility intervals. And after the 20th of April, when the schools have been reopened in part, and then more and more and more, the reproduction number is in this interval here. And here you see posterior distributions. These are useful things to look at, but it's also interesting to understand how the interventions have modified these reproduction number. And we can easily see that the reduction was of about 80% when the school closed in March, while the reduction compared to what was before the closing of the school is now only 77% after the 20th of April. So it's a little bit, it went a little bit up, but not systematic. It's interesting to compare these two numbers with other countries. And for example, in Germany, where in some sense the interventions were similar to Norway, possibly with a little bit more stricter, but there the reduction that is found here is 79%. So that is something that fits well with each other. Here you see a fit to the national prevalence data of hospitals, so the number of patients who are in hospital, who occupy a bed in hospital. And here you see that using our step function for the reproduction number, which has 3 levels and 2 change points, the fit is quite good. So we are satisfied with that level of precision of the reproduction number. Let's go back when the things were more difficult. Let's go back, for example, to April 6. That's the data that we had at that point. The number of hospitalization, the number of people in hospital suddenly had stopped to grow in the very end of March and had started to stabilize here. And the question was, how would it continue in the next 3 weeks? And what would we expect? This is the estimate of the reproduction number that we had at that time. It was between 0.4 and 1.2 at this point, so it was still large. And our predictions for the next 3 weeks, starting from 316 people that were in hospital at that point, was with a like this. It was going down with a confidence interval between 62 and 470. Large uncertainty here. And one of the points I'll make again later is that uncertainty is large. We know now how it went because we can look to the nice plots that Jari from VG is producing in a wonderful website. He is telling us that our predictions, our confidence band here in blue, was in fact covering well the true trajectory of the hospitalizations, maybe a little bit on the lower side. Why do we do mathematical models of epidemics? And we do it for 3 big reasons. First of all, we want to know where are we now? Then we want to know where are we going? And finally, we want to know what can happen if I do this and this. So the nowcast is to understand how the situation is now. So for example, how many people have been infected so far? What is the reproduction number? Give me a geographical picture, a distribution of the epidemics in Norway. Then we want to make predictions about the future, hospitalization, intensive care units, prevalence for the next 3 weeks, maybe for the next year. In particular, we're interested in peaks to find out where we challenge the health systems. And finally, we are all interested in scenarios. So what happens if I do this and this? What happens if I open the schools? What happens if we let R0 grow? Again, because we're interested in peaks and how they move, both when they come, because if they come later, it's easier to prepare the healthcare system, and how high they are. And then there are questions that are coming just now about vaccination strategies. So because we will not have vaccine for everybody immediately when the vaccine will be available, how should Norway vaccinate the population? In what order? We have several models, but the one that I'm telling you a little bit more details about today is the spatial meta-population model that is based on 3 layers. We start to distribute the 5.5 million people in their municipalities as Statistics Centralbyrå tells us it was in January this year. Then we have a compartmental model of spread. I'll tell you a little bit more in a minute about this. And finally, we have mobility of individuals between municipalities. Let me start by showing you about the mobility. Here you see 2 pictures of Norway. So mobility for us is movements of mobile phones. It's Telenor that provides us with this very precious data. It counts how many people move from each municipality out into any other municipality in dividing the day in 4 6-hour blocks. So in the first picture, you see the movements between 6 and 8 o'clock in the morning of a certain day. And on the other side, you see between 12 and 14. Mobility is important for infectious disease modeling because it tells us how the disease, the virus, is carried by infectious people from one place to another. Norway is completely empty now. We said it, we showed it a minute ago. Here it is again. It's a yellow card, a yellow map. So how will, if the virus starts to grow again, if it is re-imported from abroad, how will it move? When will it reach Trondheim or Tromsø and so on? So the mobility is an important aspect. Yeah, and well, I can also add on the mobility that it's like this, that if in any of these 6-hour intervals, if there are less than 20 people moving between a municipality and the other, then this number is censored, and we will not know it. Here you see the data, the Telenor data. In blue, it's Oslo. In orange here, it's Bergen and all the other cities here. Let's look to Oslo. This is the number, the total number of movements going out from Oslo from in the beginning of March. And here you see the 12th of March, a big drop. You see the cycle of the weekends, a big drop down here. And then it starts to go up slowly. You see, it's quite regular, this movement up, about 2% every day. People are moving again more. And what is interesting is that now we are quite back at the normal level now, quite back at the normal level. So this is very precious and interesting data. I'd like to tell you a little bit more about how we can use this data for predictions. Now, let me write xijt as the number of people who were in location I yesterday, let's say, time t minus 1, and are in location j now at time t. So this is the number, this is the matrix, one of the matrices that we get from Telenor. And xijt is the ones that don't move. Now you can prove that there is a relation between two successive matrices of this type, the matrix T and the matrix T plus 1. This equation 1 is easy to see. If all movements would be recorded perfectly by Telenor, then this equation would be always correct between the data matrices that we get from Telenor. But it is not the case, because movements escape the Telenor tracking. And we are not sure why this happens, but it could be, for example, because phones are turned off while they move, or do not connect properly, or maybe there is an exiting of the Telenor net to abroad and things like this. Now, the fact that this equation 1 is not correct has a consequence that in the long run, we are moving out people from municipalities so much that the municipalities are empty or almost empty. This depletion does not happen when we do predictions for the next 3 weeks, because it is not such a big error. But if we do prediction for a full year ahead, then we need to take into account this. And in fact, because we are going to predict the next full year by using the last week of Telenor data, for example, repeating it systematically ahead, or even just the last day, for example, repeating it systematically ahead, then we need to regularize these matrices with them in the way that is written here, which simply says that we need these matrices to have row sums equal to column sums. And one can easily see that some quadratic programming problem can be written down with some linear constraints that is easy to solve. So we have nice regular matrices that represent mobility quite good. And then going to the compartmental model, first of all, we divide Norway in its 11, isn't it 11? I think 11 fylker, and every fylke has their own 3 reproduction numbers, R0, R1, and R2. So Oslo has a different reproduction number than Vestlandet, and so on. And then we assume that once people are in a commune, in a municipality, during the 6 hours that they stay there, then they mix completely uniformly using their reproduction number that are in the fylke the commune belongs to. And here you see estimates. I'll come back to them, but these are estimates for all these reproduction numbers for all these communes. I will tell you again later that some are better than others. Now I want to make a step aside a second to think to inference. And to think to inference, I'd like to talk about the simplest compartmental model that you all have heard about it, the SIR model, susceptible, infectious, recovered. This is a simple model where everybody is susceptible in the beginning. When you meet an infectious people, there is a certain probability that you get infected, and then you move to the infectious compartment, and then you stay there and you're infectious. You can infect others if you meet them and for some times, and then when the time is over, you're recovered. And recovered here means you are either completely fine or you end up in hospital or you're even dead. Now, there are two parameters in this simple ordinary differential equations that you see here, and they are beta and gamma. And beta and gamma are the parameters that I have to estimate. Otherwise, I can't do anything with this model. In particular, the famous reproduction number is the ratio between beta and gamma. Now, if I would have nice data, if I would measure all the susceptibles and all the infected every day, well, then it would be completely trivial, or in many days, it would be completely trivial to estimate beta and gamma. Very easy. But we don't have this data, so things are not so easy. What data do we have? Well, we have the number of tested every day, and among them, how many were positive. We have the number of patients who are in hospital, occupying a bed. We have the number of COVID patients that enter hospital every day, the number of patients that enter ICU every day, and the number of COVID patients that die every day. And out of these data, I have to estimate beta and gamma. Now, the way we do it is by approximate Bayesian computing. The idea is very simple. You try to find beta and gamma that gives you the curve that you see here at the end, maybe the hospitalization curve, that fits the data best. And we do it by simply fixing beta and gamma, running our model with those two numbers. We need to see how many people are hospitalized. And here we have to, for example, say that when you are infectious, there's a probability that you end up into hospital, for example. And then we can compute curves like this. And we do it many, many, many times with many, many, many parameters and compute many, many fits to see how well we do compared to the true data. And then we take the one that is best. And this is the estimates of the parameters that we like to use forward. Well, really, we don't take only one, we take many. We take many parameters, the best ones that fit the data best, and those are the ones that contribute to these bands of blue curves that you see here. Sequential ABC is what we really use. And sequential ABC is doing the following. It tries to find good parameters iteratively. It starts by sampling from the prior. We are Bayesian in this exercise. We start with sampling the parameters from the prior, compute the distance between the predicted number of people in hospital and the data. And here we use data per fylke. So every fylke has a curve of these red dots. And then for every subsequent round, we sample the parameters that we had in the previous round, taking it out the best one with some important sampling weights. And then when we keep the best one, how do we keep the best one has to do with how good we want to improve every time. But let's say that we keep 1,000 parameters in each round. And then this ends up by having 1,000 parameter at the end. Here it is, 1,000 parameters here that we can run in the future to make predictions with uncertainty. And this is, for example, the prediction that we produce for Oslo. Here you see Oslo, these are data until this point here, and here's our prediction of the next 3 weeks. The Oslo has quite good data because we need cases in the hospital to do estimates. If we wouldn't have any case in the hospital, we can't estimate anything. Viken, we have also quite good data, it goes fine. you see that we are around, we are very, very low in both cases today, and the prediction is like this. But here you see the prediction goes a bit up at the end, right? We are a little bit unsure here in Viken what can happen in 3 weeks. And much more difficult in other fylker where we have less data or data that don't follow our model well enough. So here you see Trondelag. In Trondelag, something special happened here, right? And it went down and up, and we are in trouble here. And therefore the uncertainty is big. We are much more unsure of what happens later. Now, the numbers are so small here in any case that we are really not worried about this uncertainty. The same here for Rogaland, where we also are a bit uncertain. Rogaland, for some reason, is something that we never were able to fit very well. The model is not a simple seer. We have a little bit a more realistic model where people are exposed. So here they get infected, but first are not infectious. They don't have symptoms a couple of days. And then they either will take the path of getting infectious and symptomatic, excuse me, of getting symptomatics. And this happens in 2 steps. First, you are very infectious and no symptoms. This is what makes COVID such a tough disease to control. And then you get the symptoms and you are infectious. Or you are keeping asymptomatic all the time. You might never know that you have had the disease. And you see there are parameters here and that we have to fix. For example, the probability, once you're getting infected, are you going in this direction or in this other direction? And this is controlled by a parameter that we currently estimate to be 0.4. The infectious asymptomatics are infectious, but much, much less, less than 10% how the infectivity of the other side. I mentioned that we need a model for how people get hospitalized. And out of this model, it's only from here that patients can get to hospital. These ones, they don't have symptoms, they don't go to hospital. But from here, they can be taken out and sent to hospital. We need a model to do it. And we use Norwegian data from the Norwegian pandemic registry and the one that is called MSIS, whose letters I have forgotten what they mean. And when we finally were able to look to them, we got a very interesting picture of the Norwegian hospitalization of COVID patients. For example, we see that between onset of symptoms and hospitalization, we can move within 9 days. And when you go to hospital, 15% of the cases will end up in the ICU to get respiratory assistance, and the rest goes into a normal ward. And if in this line they stay with a mean of 6 days in hospital and are discharged. More complicated on this side where numbers are much bigger. And we use all this data here to generate the outcomes. I have to say a bit about 2 other aspects that are very peculiar and important, in particular in Norway. And this has to do with the seeding. You know, a model like the one that we have need to get the infection at the start. And in fact, in Norway, a lot of virus has been imported, as you remember, from Italy and Austria and other countries. You see in this plot, in this red, dark brown color, the quantity of imported cases. And there are quite a lot, as you see. So these imported cases are hand set into the commune where they belong to on the day where they have been tested, and they start, and this is done systematically until the 18th of March. Because we think that we are not able to find and detect all the positive cases that have been imported, we add a parameter which we call the amplification factor that acts in the following way. For every person that is introduced, we introduce an amplification factor number of copies that will then act independently. And we estimate this amplification factor to be around 2.3 currently. So this is how we seed the model and how we start to run it. I show you now predictions of the next year under the assumption that things are exactly like they are now. So with the matrix of Telenor I think, of the last Thursday, and there are zero, the reproduction number, which is estimated in after the 20th of April. And you see everything disappears, and there's nothing to observe here. It goes down, and this is the number of people in hospital. Here you see an what if scenario. So what happens if we are here, we are down here, somewhere here, that's where we are. This is a small bump in April. This is where we are, in this corner here. And what happens now if the R effective would increase to 1.1? Well, then we run our model with the mobility matrices of NORA and so on ahead in time until January 22, and we would see this uncertainty here. So there would be a peak maybe in about a year, a peak that is below 1,000, quite a lot below 1,000 of individuals in hospital. Very reasonable peak. If we would go up to 1.2 or even to 1.3, the peak would explode much higher and it would come earlier. These are interesting scenarios that can be used in discussion about interventions. And we can compute how many people would be in a respiratory at the peak. And you see that this is a number here that it's easy to satisfy in Norway. This is a number that stresses the system. This is a number that is impossible to satisfy. I conclude with one comment and then a couple of more words, and this has to do with the expertgruppe that Steiner Holden has led. It's a wonderful 150 pages document that explains how a series of interventions that we could do in the future, what would be their economical and other types of impact. And everything is based on making assumptions about the future. And Holden prepared a series of scenarios for the next 3 years. For example, H1 is that we keep the R0 to about 0.9. And this happens by imagining that we are able to keep it down until the vaccine comes in January 2024. This here is like H1, but it's less unstable. So in this case, yes, we are continuing to controlling, but every winter in the next 3 years, we are not so good. There are seasonal aspects, and R goes up to 1.25 between November and February. And then we can look to less strong interventions. Here you see one where the R is kept to 1.15, but because there is a big bølge, a big wave that comes already in September in the next year, then this will produce some herd immunity. The R will go down to 1 and until the vaccination will come, and so on, right? Then this is a case where the vaccine doesn't give, where the disease doesn't produce total immunity, for example. So we run our model, compute all the numbers for the next 3 years, antal syke hvert år, and blah, 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 here you see, with all confidence intervals. And we can make predictions about things. This is H1, number of people in hospital in the next 4 years. This is here the case of B1, where it would be a big bølge here in the middle, right? And you see the numbers here. It's very interesting because the economical consequences of all these interventions are detailed, understood in detail and valued. So here you see, for example, the expected number of deaths that are expected to happen under these various scenarios. Here you see the value of these deaths in terms of kroner. There are ways of computing these things from 1,6 billion kroner to 102. Here you see the realøkonomiske kostnader. So this is the cost to the total cost. And these are very, very important aspects. Everything is starting from running our model and showing what it would produce in the future. I'd like to say a word about other data. We have used the we have used a number of we have used both a number of COVID-19 patients who are in hospital and the one that enter hospital, and these are good data, and but they depend on the hospital stay, how long you are in hospital. So that part of the model has also been good. These data here are a little bit noisy, the more irregular, but also good. Now we could use also the number of tested and the number of positives, so the percentage of positive every day. Now the point is that the testing criteria, they change all the time, and they have changed a couple of days ago again, and they're difficult to use. We are working on this because in some sense you can imagine that the purpose is always to find all the positives that are around, and maybe this can be used to stabilize the number of tests in some way or control. Then you have also the number of deaths which could be used. Many deaths are outside hospital in Norway, so we would need to model that part also, but that's also possible. And all these data are interesting and usable to estimate the parameters of the model. It's not only beta and gamma, it's some others in addition. These data have all a delay with them. For example, when we use the hospital data that we're using today, then because if somebody will end in hospital once she is infected, then it will take an average of 14 days before this happens. So when I look to the hospitalization data now, this tells me something on how many were infected 14 days ago. So this is the delay. And some data have less delay, and some data have more delay. So this is why it is important to think to which data you want to use, also in terms of how rapidly you must capture changes in the epidemical processes. I conclude by two couple of discussion points. First, I'd like to say that we were very lucky in February because we were ready to do what we have started to do in BigInsight. We had a project where Solveig Engebretsen and Kent and many others had a model as the spread of influenza using mobile phone data in Bangladesh, and this was a very, very important paper that you can read on the interface soon, which guided us very much. Now, I'd like to say that, of course, there are very many other useful and good models. They're running many other models and useful ones, and there are even more. What I'd like to say is that it's important to think that inference is not easy for these models. They are often over-parameterized, the parameters are difficult, the data are scarce. And it is important to do inference properly. It's also very important to remember that all these models have hard hypotheses that must be justified epidemiologically or clinically justified. These are really important aspects. You cannot run these models without thinking very carefully on all the assumptions you are doing and why. Mobility is important. It is very important in the early epidemics, and it is very, very important again now when we are essentially back where we were in February with almost no cases, and we will import them again. The spatial aspect is also useful. We use data from every fylke, which is useful because we have more structure of the data. Unfortunately, the COVID disease and the system is not very well understood, and it is complicated, and it is discussed all the time. And this is why I dare to say that it's very difficult to become a self-trained epidemiologist rapidly. It's difficult to do a good job. Epidemiology is a complex science that is not easy to learn rapidly. And finally, uncertainty, which is large in this type of model, is informative. And even if it is large, because it helps decision makers, it gives worst cases, it gives indications of things. And finally, because today it's a special day, I I take the opportunity to remind us all that there are other important diseases in the world and other important epidemics in the world. And in particularly, racism is maybe the greatest virus that we see around us. I'd like to mention this right now because in a couple of hours, my children and myself and others will try to reach the American embassy to shout that we can't breathe. Racism is also asymptomatic. It can come in an asymptomatic version where you don't see the symptoms, but it is still highly, highly infectious. And for example, we adults, we infect children that are not racist. And I end up by hoping that NORA, who has a very important national role, NORA will help build AI against racism and injustice. Thank you very much. And now I will stop to share this thing. And I give, and class is back.
Thank you very much, Arnoldo, for the very important talk in these very special times. And I can also say that actually this week I had a meeting with the Likestillings- and Diskrimineringsombudet, so we are actually working with that. So thank you. So now is the time for all to write in your questions at the Q&A button. We have gotten a few questions. Jari Bakken. Why do you use a separate model for hospitalizations instead of adding more compartments to the original model?
It's a bit the same, really. You could say that ending up in hospital is a compartment, and then it's a compartment model. So I don't think that the key point is that we send patients to hospital only when they are symptomatic and infectious. And therefore, if you want, it's a compartment. And then if you want, you can imagine that there's a compartment which is the ward and a compartment which is the ICU, which is separate. So you could call it like this. The reason why maybe I could say the reason why I sort of distinguish them is that the hospitalization part is informed quite well from data that come from these registries. So we can estimate the parameters quite well. While in the other piece, there are parameters that we can't estimate from data at all. For example, the percentage of asymptomatic patients.
Thank you. Next question is from Leila Haidari Rad. I am wondering why you chose 2024 as a year of arrival of vaccination.
It was chosen by Steiner Holden. Not by us. We get very clear instructions on which scenarios to run. I also wondered why it was so late. I mean, I imagine that it can be before. That's what I maybe think and hope. But it will not come. It is not around the corner, right? This is not, I mean, we understood that when they told us in the beginning that it would take 1.5 years at least, well, that was serious. The at least was really there. And even if we try not to hear that at least, so maybe it is 2.5 years and then we are almost there. And then I understand that Norway is part of an international consortium that of the WHO that will have a policy on the distribution of the vaccines. So it will not be like the swine influenza where everybody was rushing to buy their own quotas, right? This will not be like this. Luckily.
Yeah. It's also a bit maybe scaring, I don't know, to see that your models typically predict the peak in more than 1 year from now, depending on bar.
Yes. Yeah. I thought we were done with that, right? That's what you think, right, Klaas? Yeah, but this was something that psychologically, this was something that came in us while we were doing these models in March, right? We understood that this is not going to be fast, right? And now we all know it. And
Yep. Okay, so Hans Eide has the next question. And can you say something about the computational power you needed for these models?
Oh yeah, this is an important point. So we need a lot of computational power. In particular, the sequential ABC is highly computationally demanding. You can parallelize wonderfully because you're simulating parallel streams. So we are currently running it on 10,000 cores in Saga, which is the Norwegian Sigma 2 supercomputer. We have been very, very lucky to have the full support of Sigma 2 and USIT here in Oslo, and we have a fantastic situation. And without them, this would not have happened because this has to run overnight. The longest running time we have currently is maybe one full day, and all the development is done on a server with 200 cores, where we do all the development separately. So it has been computationally demanding and hard and difficult. And it has been a little bit a miracle that that the computer power has been available for us. It's these situations where 1-2 people make the right decisions and nobody knows that they've done the right decisions, but I can tell you that I know that they've done the right decision, and they have been crucial.
Speaking of that, how important has the modeling been for the governmental decisions, you think?
I was always shocked when I heard Erna Solberg saying something that we had written, or the ministry. I mean, usually I don't think that they say the same thing I say. But this time they did, and I was a bit surprised and proud in some sense also. I mean, I'm really very, very impressed of how the political, the key political people have understood the situation and understood the complexity of what we're doing. It's really, I imagine that they have been using a lot of time to understand these pieces of mathematics and statistics, and they have understood it well enough to take the right decisions. I was in particularly very impressed when Erna Solberg was able to distinguishing a median from a worst case in a very, no, but that's not so easy, right? To understand what a confidence interval means in practice, right? And understanding what the worst case is. This is exactly what a politician has to do, right? To understand the uncertainty and to put value on what it means, right? So why do we work with the worst case? Because that's where our values are. We have to protect the healthcare system and the weakest individuals in the viral chain. So I think it was very interesting. Then there is also situations where not everything is understood, and sometimes it has been us not being clear enough. Sometimes we were wrong in telling the story in one way, and we should have said it slightly differently. But all in all, I'm impressed about this. I'm less impressed by the journalist class. There are 2 types of journalists: the ones that understand really think very good. And I'd like to again say that you read at VG and others, they have downloaded all our codes from GitHub and looked to everything, and I'm so thankful about this. And then there are another types of journalists that struggle in understanding things that are difficult, and we have tried to use time for that, and maybe we should have used more time.
Impressive to hear that journalists are downloading code from GitHub.
Wonderful, wonderful.
Okay, next. Hard pleasure. Thank you for a very informative talk. How difficult would it be to apply your model to other countries, or to compare it to results from models for other countries to understand the difference in COVID-19 dynamics in different countries?
A very important thing. So every country has their own models. Some are completely open and public, so our models are all open and public. Some other countries don't have public models. In Italy, the models, for example, are run by extremely good and extremely good people, but they're not public. I mean, we use the Telenor data that you could get also in other countries in principle. Telenor has about a 50% coverage of Norway, so that's important. But I imagine that if you would have similar data, you could use the same model also in other places, definitely. And we did a little bit in Bangladesh, as I told you before. Comparing different, now we use different models and in different countries, and we want to compare all the time our results. This is something that we do systematically. We have meetings among the Nordic countries every 2 weeks, and we read all the literature because we are desperate in understanding how the key mechanisms of the COVID are. So it's very, very important to confront with the others, understanding weaknesses and strengths and not believing everything, because things can be terribly wrong or different. That's why, for example, we were very, very excited to see the Norwegian data for the hospitalization, because they're different from all the others.
Thank you. Next question from Helvig Hauser. What have we learned from COVID-19 for the next pandemics, other viruses? What will be different in the future? Bill Gates, I think, complained that we were bad at learning from earlier situations like Ebola, etc.
We were very bad. I mean, BigInsight was quite good to think that they should do this. Let me say it with a smile. But in general, of course, we are running through this, through what we're doing, right? We are coding, not me, but I mean, we are coding all the time, and we are thinking models and developing things and trying different data all the time. And we would have liked to have much more time. So it's clear that we have not prepared for things like this in a proper way. We have not trained the enough capacity to do what we have to do now. We lack capacity. We still lack capacity, and it's not easy to build up capacity from 1 month to the other. So there has been clearly strong deficiencies in Norway and in many other countries. We have learned this, and you're completely right that this is not the last epidemics that we will get. They are different, and some are more more infectious than others, and so on. But this is not the last one, and it is clear that we have to prepare and in a different way. Schools have to learn how to run in different situations, right? Maybe we have to start to build school in a different way. Maybe we have to think how the transport system should be able to cope with things like this when we build it, when we plan it. So I think that this is to go deeply into the planning of society, and also and then there is another important aspect, which is the inequality level of a country. So we are worried about the big inequalities that is in many countries. Inequalities are strengthened by epidemics of this type. We are highly unprepared to protect the weakest part of our societies. Highly unprepared everywhere. In Italy, there have been many households without any computer at home, and that was not an exception like maybe in Norway. It was the norm. So it's a lot that we have to learn, and I think we have learned a lot. That we live in a society where the funding is limited means that we will have to prioritize less something else. And then I hope that the politicians will decide what to fund less. And maybe it is the things that are not very important.
Thank you. Great answer. The next question is from anonymous attendee. That was an excellent presentation. Thank you for your hard work. I am curious about uncertainty in data and the model. Did you consider the observed data as perfect measures? Also, did you consider the bias of the mean in the observed period history? as a way to predict the discrepancy bias between the model and forecastings in the future?
Yes. So yes, we have a model. We have an error model around the data. So we model the error of the data, and in particularly for the incidence data of the hospitalization, you need it. Otherwise, this is not working. So yes, a very important point. The likelihood of these models is very important. It describes the variation and the noise in the data that is not systematic, that comes from, you know, for example, it took some time for us to understand that people are not thrown out from hospital in the weekends. It happens only on Monday, right? And we saw these strange things every week. But I mean, some noise is systematic and you understand it, but others is really stochastic. Now, another thing is what you're saying about, I think what you're asking is about trends and predictions. So currently our predictions are using trends in the sense that we see where we are now, and then we continue with the same trend forward, right? But one could be more active and, for example, try to modify the trends in the future, not only looking to the past of the same data, but looking, for example, to changes in mobility. One could say, I see that people are moving more and more and more, then I expect R0 to go up. And we have tried a bit to understand these relations, and we have seen that Håkon Bakke has done it, in fact, and we have seen it that we have not really been able to see clearly this possibility. So there are correlations, but not enough to produce trends that we believe for the future. But in principle, it's important. This is what is done by this University of Washington, I forgot the name now, models. They look to a combination between trends and these SARE models.
Exactly. And then also a question, could you post a link to your codes on GitHub? I guess this link could be posted.
It is posted. It is on all the, we have a web page on the WHI, which you find by Googling WHI models, I think. And there you find a link to the GitHub.
That's perfect. We're now approaching 3 o'clock. So I think I will just say thank you so much for a highly relevant talk, Arnoldo. To all attendees, you can already know, go in and also sign up for next week's webinar under the events link at NORA's web pages. Next week, Nabil Belbati he's a research director at NORS and the head of smart instrumentation and industrial testing. He will have a talk titled Bio-Inspired Vision, taking smart cameras to the next level. So see you all then. Thank you very much.